Good afternoon, and welcome to our virtual town hall. During this session, we'll answer your questions and provide trustworthy information about the COVID vaccines. I'm Dr. Lainie Rutkow, a professor in the Johns Hopkins Bloomberg School of Public Health and senior advisor to President Ron Daniels. I serve as one of the team members leading our COVID planning efforts, and I'm delighted to be moderating today's session. I'm joined by my colleagues, Dr. John Links, professor in the Bloomberg School of Public Health, vice provost, and the university's chief risk and compliance officer, and Dr. Anna Durbin, professor in the Bloomberg School of Public Health. Before Anna's opening remarks, I want to mention the Johns Hopkins Get the Facts About the Vax campaign. For those of you on campus, you've hopefully seen materials related to this effort. It is a great resource for clear, accurate information. The campaign focuses on how we can all protect ourselves and protect each other during the COVID pandemic. Getting the COVID vaccine is a key way to keep ourselves and our community safe. In addition, during this session, you'll see a banner on your screen for a voluntary anonymous survey. We hope that you'll complete the survey to help us better understand the concerns of our affiliates. And to be clear, participation in the survey is voluntary and anonymous. In our announcement for this session, we ask that you please send us questions beforehand, and we appreciate the many that we've received. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. This town hall is being recorded, and it will be available for asynchronous viewing. I'm now going to turn to Anna for some brief opening remarks about the COVID vaccines. Anna, over to you.
Great. Thanks so much, Lainie. It's really my pleasure to be here today. I always take a few minutes to reflect on where we were a year ago in the pandemic, and particularly where we were with vaccine development. And I think it's just astounding. We now have 3 vaccines that have been approved under emergency use authorization. I think what's exciting is that the Moderna vaccine and the Pfizer vaccine, the 2 mRNA vaccines, are also applying to the FDA for full approval. So we'll be undergoing evaluation for full approval very soon. And exciting, even as we're sitting here talking about vaccines, we have the ACIP discussing recommendations for use of the Pfizer vaccine in children 12 to 15 years of age. We have excellent efficacy results from both the Moderna and the Pfizer vaccines in kids 12 to 15 years of age. And we're studying both the mRNA vaccines as well as the J&J vaccine and vaccines that aren't being used in this country in children younger than 12. So we've made great progress, but we certainly have much more progress to be done in terms of getting everybody who can be vaccinated. So thanks so much, Lainie.
Thanks, Anna. I'm now going to turn to the questions that we've been receiving about COVID vaccines, and these will be fielded by Anna and John. So, Anna, I'm going to start with you. Questions coming in about potential side effects related to the COVID vaccines, and is there a point when we'll have a better sense of the full range of side effects that might be associated with these vaccines?
I think that's a great question. I think what's really important to remember is that in this country alone, we have given more than 200 million doses of these vaccines. So more than 200 million people have well, I should say almost 109 million people are fully vaccinated. So have received either 2 doses of the mRNA vaccine or a single dose of the J&J vaccine. So we've acquired a lot of information about the side effects. And we know that typically these side effects include local pain at the injection site. And we know that they also include some fatigue, malaise, low-grade fever. These are the common side effects that we see, not just with these vaccines, but with other vaccines. And I think what's really important to note is that we have ways to capture rare or unusual side effects from the vaccines. And we are learning more and more about these. And I think as the vaccines are continued to be used, not only here, but also in other parts of the world, we'll continue to acquire data and to learn more. But I think the good news is that by and large, these vaccines have relatively few side effects, particularly outside of what's normally expected with vaccines. Some of the other side effects, severe allergic reactions that we saw, for instance, with the mRNA vaccines, and then the clotting issues that we've seen with the J&J vaccine are incredibly rare, meaning 1 in 100,000 to 1 in 250,000, which is really very rare. But we don't stop as soon as the vaccines go into use. We continue to collect those data and look for unusual or rare adverse events.
Thanks, Anna. Another question for you about boosters. And first, what does that mean when we hear so much talk about boosters? And at what point will we know if boosters are needed?
That's a really good question. So what is a booster? It's somewhat self-explanatory. So we give another dose of the vaccine to stimulate your immune response again, to get that immune response very robust and rapid. So for instance, we often see when we give a vaccine, we measure antibody titers, and they're quite high soon after vaccination. We know that those levels, those amounts of antibodies, can go down over time. Now, the good news with the vaccines that we've seen so far is that even out to 6 months post-vaccination, we're still seeing very good titers of the antibodies induced by the vaccine. So that's very encouraging. What a booster dose would do is to bump those titers up even higher. It's really unclear when or if, and I think probably it will be a when more than an if, we'll need a booster dose. But that's going to be driven hopefully by data, meaning that as we follow the numbers of cases in the United States, and I think it's really encouraging, the data that we're seeing. What we learned or saw today in reports is that we have the fewest number of cases in the US that we've had since last September, which is encouraging. We'll know we'll need booster doses when we start to see those numbers tick up in people who are vaccinated. What I say right now, just sort of as a public health professional, I think we have to remember, though, that we're not going to get out of this pandemic until the world is vaccinated. So right now, I think it makes more sense to give doses to places that need vaccines and to vaccinate more people with their primary series than it does to give booster doses here in the United States now. Now, that may change over time if we start to see more cases in vaccinated people in the US, and that will really drive the decision to give booster shots. And I think once the decision is made, those booster shots will likely include what we call sequences in the vaccine to cover some of the variants of concern, particularly, for instance, the South African variant. But I think we're several months away from that right now.
Got it. Thanks, Anna. John, follow-up question for you, since we're just talking about boosters. How can folks feel safe about returning to campus, knowing that there may be an eventual need for a booster or even the potential to contract COVID after being fully vaccinated?
So first, let me say that these vaccines are remarkably effective. When you compare how effective they are to, for example, the seasonal flu vaccination, these are at levels of effectiveness that are often unheard of. So what are called breakthrough infections after vaccination are rare. They're still possible, but they're rare. Now, some of you may have heard me talk about the Swiss cheese model of control measures. Basically, our approach is to use multiple control measures: masking, ventilation, vaccination, testing. And you can think of each of those control measures as like a slice of Swiss cheese. And when you line them up all together, the holes in one slice of Swiss cheese are covered up by the solid areas in other slices of Swiss cheese. So for us, it's never about pinning all of our hopes on one control measure like vaccination, but picking those control measures that in ensemble together are working well to offer a great level of protection.
Thanks, John. And Anna, since John was just mentioned the potential for breakthrough cases, John, I know that you hate that phrasing, but Anna, I want to ask you a follow-up about that. Can you talk us through what does that actually mean, a breakthrough case, or that someone can be fully vaccinated but still be susceptible?
So a couple of things. One, I think it's important to note that there were cases of what I'll call reinfection in people who were naturally infected with SARS-CoV-2. And what we saw from that experience is that they were, for the most part, less severe, more mild, sometimes completely asymptomatic. Well, we have seen incredibly few reinfections with SARS-CoV-2 following vaccination. As John has said, they have occurred, but they're very, very uncommon. And for the most part, again, they're quite mild. Now, again, the people who are most at risk for severe COVID, the very elderly, we have seen more severe infections post-vaccination in some of the elderly. But again, these are incredibly rare. I think I read somewhere that in total, it's something like 0.01% of people who have been vaccinated have a documented infection following vaccination. As I said, for the most part, the vast majority of those are very mildly symptomatic or asymptomatic, meaning it's picked up on routine testing, whether it's done for work, that sort of thing. So it can happen. I think, again, I always make the point that vaccines, the point of vaccination is not necessarily to prevent infection. That's an incredibly high bar that we don't see really with any vaccine, particularly over time. What that vaccine is doing is preparing your immune system to prevent disease. We don't want you to get sick if you do get infected. And so, as John said, these vaccines, the efficacy and the effectiveness of them are at levels we did not expect, and really are just incredible. I mean, it's really something that we could not have predicted and are just thrilled to see. And on top of that, we know that the overall effectiveness at preventing disease is incredibly high and remains high 6 months out. And that's really the important point. And that's why, for instance, when we look at CDC guidance now on people who are vaccinated, you can be inside with other people who are vaccinated without a mask, without social distancing. You can be inside with one family that may not be vaccinated. We know that you may be exposed to somebody with SARS-CoV-2, but if you're vaccinated, then you don't have to isolate if you're asymptomatic. And this just goes to the level of protection that is being seen with these vaccines. I'm incredibly thrilled with these results. It's almost unbelievable to me that we've, in this short amount of time, found so many effective vaccines, deployed them, and really demonstrated the real world effectiveness against the original strain of SARS-CoV-2, against the B.1.1.7 variant that's circulating in this country. I think the news is good, and I think the protection from these vaccines is, longer than 6 months, maybe a year, maybe 18 months, we don't know. But I think we're starting to now reap the benefits of widespread vaccination. And the best thing we can do is to continue to get as many people vaccinated as possible and continue to use those other Swiss cheese methods that John mentioned.
Thanks, Anna. And before I ask you the next question, I want to remind those who are watching, please, as you think of questions during this town hall, please do submit them in the box that you see on your screen. This is what we're here for in this hour. We really do want to answer any questions that you have about the COVID vaccines. So, Anna, question about understanding whether the vaccine has worked once you receive it. So is there any way for folks to assess their immunity status once they've been fully vaccinated?
That's a great question. And I'm going to give, I don't want to say a wishy-washy answer, but I'm going to give an answer that may not make everyone happy. So there are, you can go out and you can check your antibody levels after you're vaccinated. It's not recommended to do so, but you can do that. And if you do that, you have to make sure that it's antibodies specific to the spike protein. But I will say this, that we don't know what level of antibodies, particularly in this test, is protective or not. And if you don't have antibodies after full vaccination, we don't know that you're not protected. We certainly have seen, people who haven't mounted antibody responses, particularly those people who are on certain immunosuppressive therapies that can affect their ability to make antibodies, but they've responded. Another part of their immune system has responded. But if people are very concerned, and I've had people in the clinical trials that I'm running and people who have gotten vaccinated have gone out and checked their antibodies to the spike antibody. And it does make some people feel better to say, oh, look, I have a number and that means I did respond. But really, these vaccines, we know from the clinical trials that they are, in the people who were given the vaccine, completed the full dose of vaccinations, are 95 to 100% protected against severe COVID disease for the mRNA vaccine trials. We know that the vast majority of these people, they only did a sub-study to look at the immune responses, but people in the, more than 99% of the people responded by antibody titers and other measures. Now, again, people who had immunosuppressive conditions weren't enrolled in these trials. Certain immunosuppressive conditions and on certain immunosuppressive medications weren't enrolled in these trials. But I would say if you're a healthy adult person who, for instance, isn't on medication, immunosuppressive medication for organ transplant or severe autoimmune disease, you will have responded to these vaccines, and you don't need to have your antibody titers tested.
Thanks, Anna. Another, no surprise, lots of questions for you in this area today. So another question for you: if someone does get COVID after they've been fully vaccinated, is there reason to believe that they won't get as sick? And could they? Do we know if they can still experience what folks call the long haul version of COVID?
So we don't have really enough cases to know about the long haul COVID. If you've been infected post-vaccination, we just don't have enough cases of people who were infected post-vaccination. What we do expect and what we have seen is that the majority of people who have been infected post-vaccination do have very mild illness. As I said earlier, there are some people, particularly those who are elderly or who have other factors that make them at higher risk for severe COVID, obesity, heart disease, diabetes. There have been cases of severe COVID in those folks. But again, the numbers are so small that we can't say whether or not you're still at risk for long haul. As an infectious disease physician, I would say that if you got wild type COVID and you got more severe disease post-vaccination, that you may be at risk. We just don't have data yet.
Thanks, Anna. And we've talked a little bit about side effects. Mm-hmm. What about long-term effects? And what do we know, especially since these vaccines are pretty new?
Mm-hmm. Well, as I said, both Pfizer and the Moderna vaccine are applying to the FDA for full approval. And one of the requirements for that is that they had to have safety data for 6 months. So I think it's important to note that for most vaccines, to go for full approval, you don't need years and years and years of safety data. Now, most vaccines do have longer periods of time to collect the data because they don't get their efficacy data in such a short period of time because they don't have the numbers of cases. We're not, they're not being done in a pandemic like these vaccines were. Again, what I would say is very reassuring is that we're not seeing long-term safety complications from the vaccines. Now, one of the things that the FDA always looks at in terms of vaccine safety is autoimmune disease. Are you predisposed to have different types of autoimmune disease? We've not seen that in these vaccines yet. I think the other thing that's a little bit different about these vaccines, maybe a little bit different, although they're messenger RNA vaccines, so we don't have a lot of experience with them in the long term. They're not given with an adjuvant. And we know that some of the issues that we've seen with vaccines are related not so much to the antigen in the vaccine, but to the adjuvant or the helper chemical that's given with the vaccine to stimulate your immune response. The mRNA vaccines are delivered in what we call just sort of a fat envelope. And right now it doesn't, and the mRNA vaccines don't last for very long in your cells. They're gone within a few days. So we don't believe that you are at higher risk for these long-term complications from the vaccines. And to date, we haven't seen any evidence of that in our safety monitoring systems, and of which we have several going on in the US to try to find cases of any vaccine-associated complications.
Thanks, Anna. Another question for you. So many of us have heard, and some of us have personally experienced, that with the mRNA vaccines, folks tend to feel a little worse after the second dose. Given that, do you anticipate that a booster would also have similar side effects for, I don't know, 12 to 24 hours or so, at least based?
Yeah, that's a great question. I know that both companies are doing booster studies right now. We don't have the data from those yet, so that will be very helpful in terms of helping us better understand that. It's really interesting. I think it will depend somewhat on your immune status at the time of your booster. So if you're still having, for instance, good antibody titers, you may not have as much of a reactogenetic or so much fever, malaise, fatigue, that sort of thing with the booster. But if, again, your immune response is sort of waned to low levels and your body sees that booster shot and really recognizes it and gears up and really produces a lot of what we call immune mediators, cytokines and such, which tend to cause the fever and the malaise. So you're getting a very robust immune response. You may, in fact, have some of those. So actually, from a scientific point of view, I'm really interested to see the data that are coming out with these booster shots. We know from the adolescent trials, the 12 to 17-year-old trials and the 12 to 18-year-old trials that are done by Pfizer and Moderna, that those adolescents have more reactogenicity than even the younger adults, and they also have a more robust immune response. So it does look as though that those side effects may be tied to the robustness of an immune response. Now, that being said, I do want to clarify that if you haven't had a lot of side effects with your second dose, that doesn't mean that you didn't have a good immune response. That's not what that means at all. It just means that some people are more sensitive to some of those mediators and sort of feel them more.
Thanks, Anna. And as long as we're talking about side effects, and we have more questions coming in on that topic, so I'm going to stick with you and that. How do we think, especially with the mRNA vaccines, because this is a new technology, about future health issues? And the one that I hear about concerns about the most, and I think it's probably the same for you, has to do with fertility.
Yeah. So I think what's important to note is that when you're given the mRNA vaccine, so you're given it as a shot in the muscle in your arm, those vaccines do not stick around in your body for more than a few days. And the material, what happens is that mRNA vaccine is delivered in, as said a little bit earlier, a fat particle essentially. And that gets it into your muscle cells at the site where the vaccine is given. Your muscle cells then take that vaccine material and your body uses it to make the spike protein of the SARS-CoV-2 virus, which then is shown to your immune system and you get that response. The vaccine doesn't go to any reproductive organs. We've not, all of the manufacturers have to do something called reproductive toxicity studies in animals as part of their licensure process. And they have not seen any signs of effect on pregnancy or fertility in the animals. We know that from the studies and from the vaccine programs here in the US, that thousands of pregnant women have been administered the vaccine. It hasn't affected pregnancy. We're still waiting for some of those babies to be delivered, but there haven't been increased reports, for instance, in pregnant women who have been vaccinated, of miscarriages or problems with the pregnancy. We won't know, of course, long-term about fertility until over time, but what I would say is that there's no reason to expect that the vaccine itself would have any effect on fertility, given the way it works and how it works in the body and how it's delivered. And certainly the risk that one would get from a COVID infection is likely to be, far, far worse. We don't have any long-term data, for instance, on COVID and fertility either. But I can say from the studies that have been done, what we call preclinically, meaning before they come into the clinic, usually in animals, there doesn't appear to be any effect on fertility. And by the mechanism that these vaccines work, they aren't directed to organs of reproduction. They don't target those organs of reproduction. And the mRNA material is degraded within days of it being given. So although I don't have a crystal ball and I can't say anything for sure, what I can say, all the data point to that these vaccines being very safe in young men and women of reproductive age without an effect on fertility.
Thanks, Anna. And I want to thank everyone who's submitting questions. I see them coming in and I'm keeping a close eye. We will get through them in this town hall. So, Anna, another question for you, and I'm going to combine a few questions with this one. Can you give us a quick rundown on the different vaccines? So we have the mRNA vaccines, which are Pfizer and Moderna, and then the adenovirus vector vaccine, which is J&J. But can you just kind of talk us through, please, big picture, what the differences are and how they work?
Sure. So we have the messenger RNA vaccines, and what I like the name because it sort of tells you what it does. So how does that vaccine work? Well, it's a genetic message. So it's RNA that's delivered, and it has to be delivered in that fat capsule to protect it because it's very easily degraded. And what happens is that RNA gets in your cell, and we make messenger RNA all the time. It's how we make proteins in our body. It's how our body works. So our cellular machinery sees that messenger RNA and says, hey, that's a message. I need to translate that message and make a protein from that. So your cells translate that message in the cytoplasm, in the cell, and they make the SARS-CoV-2 spike protein. And then they send it out, and your body recognizes it. Your immune system recognizes it and says, hey, I need to make antibodies to that. That doesn't look like it belongs in the body. I'm going to make antibodies, and I'm going to make an immune response. And so it's really taking that message and translating it into a protein. The adenovirus vectored vaccines use sort of a similar mechanism, but it's a little bit different. So instead of using RNA, the adenoviruses are what we call DNA viruses. So their genome is DNA, not RNA. And what they do is they have encoded the spike protein of SARS-CoV-2. Sort of the DNA code for that is put into the adenovirus vector. And then the vector, I describe it more like a Trojan horse, because this adenovirus doesn't replicate, it doesn't make more virus. But what it does do, it gets into the cell. So it's able to get into the cell, and it delivers the DNA of that spike protein into the nucleus of your cell. Your cellular machinery in the nucleus says, hey, I'm going to make messenger RNA from that. So then it makes the message gets into the cytoplasm, and then just like the messenger RNA vaccines, it's translated into the spike protein. And what I like about both of these vaccine platforms is because of how they do that. That spike protein is made within the cell, your own cell, and then shown to the immune system. It makes a very complete immune response. You just don't make antibodies. You also make what we call a T cell response, a CD4 T cell and a CD8 T cell. And those T cells help your body make better antibody. And they also, when they recognize a cell in the future that's infected with that virus, your cytotoxic T cells will then work to clear the virus out of that cell and kill any of those infected cells. So it's a very broad, it's making an immune response that's very similar to the immune response you would get if you were actually infected with the virus, but it's in a very controlled manner so that you don't get sick, and it's only presenting the spike protein.
Thanks, Anna. And another big picture question. Can you please talk us through the difference between an EUA, meaning emergency use authorization, which is what we have right now for Pfizer, Moderna, and J&J in the US, versus full FDA approval?
Sure. So I think it's important to note that an EUA was a mechanism that was designed just for this kind of occurrence, a pandemic. We need to get a drug, or we need to get a vaccine made and in use as quickly as possible. So the FDA is not going to require months and months and months of safety data, or go through and make sure that the company has all these different studies that they have to do for full licensure, such as what we call lot-to-lot consistency study, meaning that they can make each lot exactly the same way, and other differences that they have in the approval process. And with an emergency use authorization, you essentially have to show safety for a shorter period of time. So for these vaccines, they had to have safety data collected for 2 months for every volunteer that they enrolled in the study, and they had to show efficacy data. So, and that's efficacy is how well does the vaccine protect against the virus that you're looking for. So how well, in this case, does it protect against symptomatic illness caused by COVID? So once you've met your efficacy endpoint and you have too much of safety data, you can go to FDA and you can say, I'm looking for an emergency use authorization. What the FDA does then is says, okay, we're going to give you emergency use authorization, but before you get our full stamp of approval, we have other criteria in place. And as I said earlier, that generally is at least 6 months of safety data. And then they also will go through inspections of all of the plants that are making the vaccine, make sure that all of their manufacturing processes are completely reviewed and within the guidelines of good manufacturing processes by the FDA, make sure that they've demonstrated they can make the different vaccines in these different plants the same way each and every time. And that they will also present all of the data that they've acquired over that 6-month period of time in terms of what we know about now efficacy in special populations, safety in different populations. Have we identified any safety signals along the line that need to be addressed? And it will take, as people probably remember, from the time a company applied for emergency use authorization until the time it was issued was anywhere from about 2 to 3 weeks by the FDA to get full approval, even though both Moderna and Pfizer have either applied to the FDA or are just about to apply to the FDA for full approval. It will likely take months before all of those data will be reviewed and they'll receive full approval by the FDA.
Thanks, Anna. We're hearing a lot about variants these days, both within the US and given the global situation right now. What are your thoughts about the COVID vaccines and protection against variants?
So I'm very encouraged. I'm encouraged for a few different reasons. So we know now that the B.1.1.7 variant, which is the UK, it was first identified in the UK, is now the dominant variant in the United States. And we know that the vaccines have very good efficacy against this variant. The data on efficacy, or effectiveness, I should say, because it's real world data and not in a controlled clinical trial when we talk about effectiveness. So we're seeing very good effectiveness against the UK variant. And this has been shown in the US, it's been shown in the UK, it's been shown in Israel, it's been shown in different countries that have high vaccination rates and have the variant circulating. My other point of encouragement comes from the J&J trial in South Africa and the Novavax trial in South Africa. Novavax is another vaccine that will likely be applying to the FDA for EUA shortly. It's what we call a subunit or a nanoparticle vaccine. But these trials were done in South Africa, and they were done at a time when the B.351 or South African variant was circulating. And although we know from all of the vaccines, the mRNA vaccines, the J&J, AstraZeneca, Novavax, when we look at how well the antibodies recognize and sort of neutralize some of these variants, we know that they neutralize the South African variant less well. So it takes more antibody to neutralize the South African variant because of some of the mutations. But what was really encouraging is that although both Johnson & Johnson and Novavax the vaccine was less effective against mild to moderate COVID than it was against the original strain. It was highly effective against severe hospitalized COVID and death caused by the South African variant. So for instance, the J&J vaccine, which and it's difficult to compare antibody titers between vaccines, but appeared to have lower neutralizing antibody titers, induced lower neutralizing antibody titers, probably because only a single dose was given. That vaccine was 85% effective against severe and hospitalized COVID caused by the South African variant, and 100% effective against deaths caused by the South African variant. So I think that's very, very encouraging. There's a new variant out there in India, the B617 variant. It has some of the same mutations as the South African variant. We don't really have data about efficacy or effectiveness of these vaccines against the South African variant, but I think those data will be coming in soon. What I will say is the most effective way to prevent the emergence of these variants and to stop the transmission of these variants is vaccination. And that's why we have to really look outside of the United States and get the rest of the world vaccinated. Otherwise, we're going to be seeing new variants coming up all the time.
Thanks, Anna. I'm seeing a couple of questions around the theme of why do you need to get vaccinated if you know you've already had COVID, meaning you had a positive test. So what's the reason that folks who already know for sure that they had COVID, why should they also get vaccinated?
So I sort of use the same rationale as why you need 2 doses of a COVID vaccine as opposed to 1 dose. So particularly if you just had a positive test and you didn't have symptoms, we know that to some extent, the severity, those people who have had more severe disease have higher titers of antibodies. So you may have been infected, but you may not have mounted a very good immune response. And what that vaccine will do is really bump or boost that immune response to very high levels. So you will have more durable protection, meaning that your antibody titers will be higher for longer than after natural infection, and that you'll really get, I think, a very broad, really high quality immune response with the vaccine. And when you've just sort of barely been exposed or you have a very limited infection, that protection you have may be very short-lived, and I think it behooves you then to get vaccinated to ensure that you're going to have a very good, durable immune response.
Thanks, Anna. And a follow-up for those who know that they've had COVID, is there a certain amount of time that they should wait before they get vaccinated?
That's a great question, and CDC has changed their guidance on this a bit. So what CDC is currently saying is that you should wait until you're no longer symptomatic, and if you were to be in isolation, you should no longer be in isolation. My general recommendation is I would wait probably longer than that. I would probably wait 1 to 2 months post-infection for a couple reasons. One, we know that from natural infection, you're likely protected for 2 to 3 months at least. And early on, we were saying it's good to wait so that we can stretch those doses a little bit farther. But the reason I think it's good to wait about 1 to 2 months after your infection is to sort of give your immune system time to calm down after that initial infection, so that when you see that first dose of vaccine, you get a very good boost. The other reason we recommend waiting about 1 to 2 months is because we do know that people can have late symptoms of COVID that occur after their acute illness, whether it's what we call MIS-A or MIS-C, the multi-inflammatory syndrome. Also, there can be long haulers. You can have symptoms that last a long time. And we recommend waiting because we don't want to confuse symptoms with COVID with symptoms that may have been brought on by the vaccine, to try to separate that. But my real rationale for waiting 1 to 2 months is really to try to give you the best immune response to the vaccine that you can possibly get.
Thanks, Anna. I'll give you a break for a few minutes and turn to John. John, is the university going to have a way for folks to let us know that they've been vaccinated, and what happens for those whose COVID vaccine card has been damaged or lost?
So yes, the university is developing a vaccine management system that is similar to what we've used for flu vaccination, where students, staff, and faculty will be able to upload their documentation. That documentation could be the CDC COVID vaccine card, but it could be other forms of documentation as well. If you got your vaccine at a pharmacy, Rite Aid, CVS, Walgreens, et cetera, it could be the prescription with your name on it. It could be if you got it in a healthcare system from your MyChart or other patient-facing account. So anything that has your name, the vaccine particulars, the dates, if it's a 2-dose vaccine, et cetera, we will accept as documentation. So it doesn't have to be the CDC card. We hope to launch that system July 1st.
Thanks, John. And another question for you. It's already been announced that students will be required to get the COVID vaccine. Can you talk us through the exemption process for students and then comment on how that exemption process would potentially work if it is required for faculty and staff in the future?
Sure. So first, let me remind everyone about the seasonal flu vaccination. So this past year, the entirety of the university, we required anyone coming on campus, students, staff, or faculty, to have the seasonal flu vaccination. That requirement had, in fact, already been in place for the School of Medicine and the entirety of the health system for 10 years. So we actually have a pretty good history of experience with requiring vaccination, with requiring proof of vaccination, and with the exception process for medical or religious reasons. This past year, for the entirety of the university, we took the process that had been in place for the School of Medicine and the health system and applied it university-wide in terms of exceptions. We are doing exactly the same thing with the COVID vaccine. So there is a process for a medical exception, and there is a process for a religious exception. And as I said, those processes are the same as for the flu. Now, for the medical exception, the reasons for a medical exception for the COVID vaccine are different than the reasons for a medical exception for the flu vaccine. It's basically the risk of an allergic reaction to the COVID vaccine or any of its ingredients. But the process is the same. Right now, only students are required to have vaccination or an exception to be on campus in the fall. Staff and faculty are strongly encouraged to be vaccinated. And if you've been listening, you know that while there's been questions about the risks of getting vaccinated, for us, those risks pale in comparison to the risks of not getting vaccinated. And so we strongly encourage staff and faculty to get vaccinated. At some point, it may be a requirement of being on campus for staff and faculty. And the same exception process will apply.
Thanks, John. Anna, I'm going to turn back to you now. What do we know about individuals who have severe allergies? Should they be concerned about getting a COVID vaccine?
That's a great question. So what we say is they should certainly disclose if they've had, and when we say severe allergic reaction, what we mean by that is generally requirement to use an EpiPen for that. Now, it's not clear from the data that we have now. Again, the risk of severe anaphylaxis or severe allergic reaction with these vaccines, and we seen it more with the mRNA vaccines than we have with the J&J vaccine. But there hasn't, for instance, been a tie to, oh, if you have a risk of allergy to bee venom, you're at higher risk for having an allergic reaction to these vaccines. If you're at higher risk, if you have peanut allergies, it hasn't worked that way. What we do know is that people who have had a severe more people who have had a severe reaction to the mRNA vaccines have had in their past at some point allergic issues or a severe allergic reaction. And what we recommend is that they just be watched for a longer period of time. If somebody does have a severe allergic reaction to one of the vaccines, again, it's why we require vaccination sites to have EpiPens available on site and know how to treat that. So it's easily recognizable. All of the severe allergic reactions have occurred generally within 15 minutes. Almost all of them have been within 15 minutes, all have been within 30 minutes, so that you stay at the vaccination site, you're monitored, and it's picked up on. So you shouldn't be concerned per se about that. We just need to watch you a little bit longer. It's not exactly clear what people are having the allergic reaction to in the mRNA vaccine. So that has not really been discerned. We think that it probably has to do with that lipid envelope that I've talked about in the past. We know that that's made up of something called polyethylene glycol, which anyone who's had a colonoscopy knows what PEG is because they've taken that as part of their colonoscopy prep. But generally, as I said, most people who are coming for mRNA vaccines don't know if they've had an allergic reaction to polyethylene glycol or not. Because it's not given very frequently, and when it is, it's generally given orally. But if you have had a severe allergic reaction in the past to anything, let the people at the vaccination site know. You'll be watched for 30 minutes. And again, it'll be picked up on, and we have everything we need at that site to treat an anaphylactic reaction, and then an EpiPen, oxygen, all of that.
Thanks, Anna.
Mm-hmm.
A few weeks ago, we heard a whole lot about the J&J vaccine and safety concerns. So bottom line question, is the J&J vaccine safe?
So the J&J vaccine is safe. What we've heard about is something called TTS, which is thrombosis with Thrombocytopenia Syndrome. And what that means is blood clotting with low platelet counts. And this is different from the usual type of blood clotting that we see, for instance, in elderly people, or has been reported, for instance, in women taking birth control pills. We know that they're at increased risk for blood clots in the leg and maybe in the lungs. This syndrome is different, and it's different in a couple of ways. One, as I said, it's associated with low platelet counts. And it's also, these blood clots are in unusual places, generally what it's called CVST, which is cerebral venous sinus thrombosis, which is in the veins that circulate around your brain. It is, again, very rare. We're looking at 1 in 100,000 to 1 in 250,000 people. And I think the reason I want to make a point, the reason that J&J vaccinations were paused in the US was, I think, a very reasonable thing to do. And it was really to get, one, more information about the syndrome, and two, to inform healthcare practitioners how to treat it. Because the one key difference in terms of how you treat this syndrome is you do not want to give people heparin, which is what we usually give. It's a blood thinner. It's a particular type of blood thinner that's given when people present, for instance, with a blood clot in the leg or in the lung. In this case, you don't want to give heparin because it can make it worse. So we give a different type of blood thinner to treat this. This has also been seen in persons who have received the AstraZeneca vaccine in Europe and in the UK. And we know that it tends to occur in younger women. It's more frequent in younger women, although it has occurred in men, and it has occurred in people over 60 years of age. But the highest risk is really in women 30 to 50 years of age. It occurs within 2 weeks of vaccination. So again, it's very, very rare. The CDC had reviewed the data a couple weeks ago and recommended that use of the J&J vaccine continue. I think what's really important is that when you're going to get vaccinated, if you have questions, if you have concerns about any of the vaccines that are offered, please ask questions. If you're uncomfortable getting one vaccine or the other, it's interesting. Some people prefer the J&J vaccine because it's a single dose, easy to get. Others prefer, and it doesn't have some of the reactogenicity that the mRNA vaccines have. But I think it's important to note that if you're a little bit unsure of whether or not you want to get one vaccine or the other, ask questions. And if you've come to the conclusion that you do prefer one vaccine over the other, I think, there is more choice out there now, and you can, not get vaccinated that day and go to another site, go to another place. But, the vaccine is safe. We're continuing to collect data on the J&J vaccine. It is important, and what I tell people who are going to get the J&J vaccine, if you have, and this information is also on the CDC website, but if you have a severe headache, if you have a fever, if you have nausea, vomiting, abdominal pain, other symptoms within 2 weeks of receiving the J&J vaccine, should go to your health provider or go to the emergency room. And I always say this, make sure you tell them, I got the J&J vaccine, I'm concerned about the blood clots, and I want you to check my platelets, because platelets is the one discerning factor. If the platelet count is low, then they will start treatment with a different drug.
Thanks, Anna. Question for you about with the mRNA vaccines and the timing of the second dose. So how critical is it for that second dose to be right within the 3 or 4, depending on the vaccine, week window? What happens if it's a little bit outside of that window?
That's a great question. So it's more important that you don't get the vaccine too early than it is to wait longer. So for instance, if you give the second dose too soon, you're not really going to get that good benefit, that good boost of a benefit. So if you have to miss the appropriate timing, it's better to wait a little bit longer. And the CDC has revised their guidance to say, yes, you can go out to 6 weeks. What we're really balancing with this is your risk of getting COVID between dose 1 and dose 2. The longer you wait, then the greater the risk of getting COVID in that interval. If you wait 2 months from your first dose, you're likely going to have a very good immune response, but you're also increasing your risk of getting infected in the interim. And that's really why we want to keep those intervals to the intervals that were studied in the clinical trials, because we don't have data. We don't have good data about how long can you wait? What is your immune response if you wait 4 months, if you wait 6 months? We don't have those data, because in the clinical trial, you got your second dose at 3 weeks or you got your second dose at 4 weeks, and there were very few cases of waiting longer. There are some studies that are looking at increasing the interval, and we do know from some of the other vaccines that are being used outside of the United States that an interval of 2 months looks to be a nice sweet spot, but we haven't looked at that for any of these mRNA vaccines.
Thanks, Anna. What about folks who, for one reason or another, don't want to or can't get vaccinated in their arm? Is it okay to get a COVID vaccine somewhere else?
It generally is. I think what's interesting is, when we vaccinate adults are used to being vaccinated in the arm. And one of the things that you want to be careful of as you're administering any type of vaccine or needle, you want to make sure that you avoid any nerve that may be in the area or any joint. So if you're giving it in the thigh, that sort of thing. Also, you have to make sure you use the right size needle, particularly for people who might be a little bit heavier, and sometimes where that is, it may change the length of the needle. But it's really, there's no secret, it's not like a secret sauce. It has to go in, part of the recipe, it has to go in the arm. No, it doesn't. Any good muscle, you just want to put it in the muscle. You don't want to put it under the skin. You want to put it in the muscle.
Thanks, Anna. And for those who have received monoclonal antibodies, is the recommendation still to wait 90 days before being vaccinated?
That is the recommendation. People are looking at data. I'll be honest with you, I didn't understand that CDC guidance, why it differed between monoclonal antibodies and natural infection. It still doesn't make a whole lot of sense to me. But that is the recommendation from the CDC at this point.
And has anything, we talked about clotting and the J&J vaccine, anything on that front to talk about with the Pfizer or Moderna vaccines?
So I think, yeah, the data are very very clear in the more than 200, I believe, million doses of the Pfizer and the Moderna vaccine combined. We don't have any cases of this particular syndrome. So we don't have any cases of getting blood clots with low platelets. So we think that it is something to do with that adenovirus vector, because we're seeing it both with J&J and with the AstraZeneca vaccine. We haven't had reports from Sputnik 5, which is also an adenovirus vectored vaccine, but the thought is that the reporting may just not be there, that there's not good investigation or surveillance for these cases and not good reporting. But we really think that it has something to do with the adenovirus vector. We don't know what it is. We don't know exactly what it is that's causing that.
Thanks, Anna. And we're closing in fast on 3 p.m. So I'm going to sneak in one final question for you. What do we know about the ability of folks who are fully vaccinated to transmit the virus that causes COVID?
We know that it's possible, but incredibly low. So what do I mean by that? We know that if you are vaccinated, if you're exposed to the virus, you may get that virus in your nose and you may pass some virus particles out, but it's the rate is extremely low and it's extremely uncommon. So again, although possible, it reduces the amount of virus that's being transmitted and the duration. So it's very effective at reducing transmission.
Thanks, Anna. I'm going to make that the last word for this town hall since we're down to our last minute together. I'd like to thank John Links and Anna Durbin for joining me today and send a big thank you to everyone who joined us, and especially to those of you who submitted questions for John and Anna to answer. If you have not yet received a vaccine and are interested in doing so, you can get help making an appointment at the COVID testing sites on campus at Schreiber Hall, at the Glass Pavilion, at the Student House at the School of Nursing, at Maestro's Cafe at Peabody, and at SICE in DC. Plus, we plan to host vaccine clinics on campus. The first one will be happening next week on Thursday. Please keep your eye out for an email that will provide additional details about that. If you haven't already done so, I'd ask that you please take a minute to complete the survey on the viewer webpage for this event, or you may see it as a banner on your screen. This will help us to better understand the vaccine-related concerns of our affiliates. And as I mentioned at the beginning of this town hall, participation in the survey is both voluntary and anonymous. This town hall will be archived and available for viewing. I hope you've enjoyed the session, and please remember, the COVID vaccine helps us to protect ourselves and our communities. Thanks, and stay safe.